just a little bit about a little context here. So I'm not an expert on health and housing, but I've done housing research for 35 years, and it's always come up. And I had an opportunity to write an article for the North Carolina Medical Journal, which I would highly recommend, not necessarily my article, but the other articles in here. And in fact, Greg and some of his people have a piece that's related to the piece I did it, but it's about focusing on the social determinants of housing. So how does housing affect people's lives, their interactions, their health? So again, it's getting beyond what the typical medical journal would normally look at and getting into more of the contextual factors and really getting into a key concept that we all have to embrace, and that is the idea of prevention. And I'll never forget, I was part of the Leadership North Carolina program, and if you know anything about that, they take you around and introduce you to various issues and topics around the state. And we were down in Wilmington, and we had the head of the, I guess it was the county public health agency come in, and he had a big bag of pennies, and he walked around the room and he put 3 pennies in front of each of the people in the room. And then he went on to say, the reason I gave you those 3 pennies is because for every dollar spent on health care, 3 cents is spent on prevention. 3 cents on prevention. So it doesn't make sense economically. It doesn't make sense humanly in terms of waiting for people to get sick before we then intervene. And what we heard from David and what we're going to hear from the panel are really all in the realm of prevention, trying to get people into housing and neighborhoods that aren't going to cause them to have this plethora of health problems and that aren't going to, that will give them easy access to medical care, so they get in there early and they don't get in there after it's too late to really make any serious health interventions. The other thing I would say from my own experience before I start throwing out some questions here is that I've been doing a lot of research for the Charlotte Housing Authority. And we're doing a lot of surveys of the people that live both in the developments and in Section 8. And on our surveys, we have questions on, we ask them height and weight, so we do the body mass index. We ask them about asthma. We ask them about hypertension. We ask them about diabetes. Just an amazingly high rates of all those things. Obesity rates over 60%. Hypertension and asthma in the 30% range. And then people are saying, well, these people need to get jobs. They need to get on their feet. They need to pull themselves up by the bootstraps and the like. And when you've got that kind of health problem going on, with all the other obstacles, it's very, very difficult for these people to be able to live productive lives in the sense of being gainfully employed. So with that little introduction, let me throw out a first question. And that is, there it is. So David did a wonderful job showing how the two fields of public health and planning started basically together and have moved apart and are now starting to move together again. But obviously we're not really there. Obviously we have funding streams and stovepipes and regulations that inhibit this. So my first question to the panelists, and I'm going to ask the national folks first, if we could start with Marty and then maybe go to David. What are the obstacles to better cooperation at the federal level? And then I'm going to ask our other panelists about obstacles to coordination of healthcare and housing at the local level. So, Marty, do you want to start in terms of telling us what those obstacles are?
Thanks, Bill. Before I start, just another shout out to DHIC and the work that you've done over the last 40 years and for putting this panel together and being mindful of all of these issues as you go forward. So congratulations. I'll start with there are many obstacles, so I'll try to pick out sort of my top list. I think I'll start with financing, because money tends to start everything. And when we look at housing and the production of housing and affordable housing, and particularly when we're looking at very vulnerable populations, seniors, people with disabilities, very low-income families, we see a certain stream of how the money comes into states and communities. And then when we look at healthcare, we see a completely different stream of how services come in to the state. Medicaid, for example, comes in through a state Medicaid agency. There's a single person identified in every state that is responsible for Medicaid policy. Medicaid's 23.7% of, on average, of the state's budget. So that person tends to spend a lot of time in the governor's office talking about how to keep that in control. And it has to be balanced every year. So on the healthcare side, for people who are, as you said in the Charlotte example, a great number of those folks would be Medicaid recipients, many on Medicare. Those streams of funding comes in a certain way. It's controlled by the state, largely. And even with the Affordable Care Act, the decisions are still being made at the state, choosing to take it, what they choose to take, how they choose to spend it. And we've had drivers for many years, cost drivers, in long-term care, which represents well over 20% of the Medicaid budget, where we're paying for people to live in institutions at $90,000 a year. But we have a very difficult time pulling that money over to help people live in their own home and to get the kinds of services and resources that they need. And they're not connected at all, HUD and HHS up here, about that policy. They've recently, by the way, begun to have these discussions about policy. Interestingly enough, and sadly enough, they were brought together in this discussion by the Department of Justice, because neither organization is complying with Title II of the ADA about integration of people to live in the community. That's their sort of common denominator today. So I think how they're funded, I think how policy is set, who makes the determination is probably the first big obstacle. Being in the room with folks when they're trying to talk to each other, they're trying to find ways to come together to say, if we shifted more resources here, would that help people live in their own home and be successful? But there's lots of things that get in the way. And many meetings in Congress, by the way, which has certain ideas about how to make that happen as well. Some of those are very good, and some of those are really, scratch your head, what's that about? So I'd say that policy making is the first obstacle, and the funding. The second obstacle, I would say, goes back to what do we know? We've heard some really good data here this morning, but what do we really know about sort of at scale if we gave everybody a decent place to live, okay? A decent place to live that's affordable, that's safe, okay, and is healthy. If we gave everybody a decent place to live, what would happen with our healthcare costs in this country? Most of the research is by project or even by property. Lennox Chase, great example. What do we know if we had 50 Lennox Chases? Because you can't turn the Medicaid dollar until you get to scale. I actually sat down once in a meeting at the Centers for Medicaid and Medicare Services with the person responsible for all long-term care and disability services, about, I don't know, $300 or $400 billion worth of responsibilities. And there was a researcher there from Chicago with us. I was with a small group of people. And they had this great project in Chicago where Cook County Hospital and another county hospital were putting their own resources in to help older, I'd say 40, 50-year-old guys who were recycling through the hospital, who have had substance use problems and HIV/AIDS. And they could show a reduction in this cohort and add a controlled study of the number of days of hospitalization after somebody got into affordable housing that was supportive. And they showed fewer visits, and they could show the dollars. So the woman at CMS said, "This is really great." She said, and he said, "Yeah, these 30 people are really doing great." And she said, "Did you mean 300,000 or 3,000 or 30,000? No, his research was on 30. So, I mean, she was a very nice lady, but she kind of closed her book at that point and smiled, and I could say, "Oh, this meeting is over." So going to scale with what we know. Now, there's probably an argument that, do we make policy in this country on evidence? You're the academic. If we did that, we wouldn't be in this room today, right?
I think the answer is, it depends.
But I remember having, I've spoken to a lot of legislators in my life, and they always start out with "young lady, do you realize, who you're talking to?" And one gentleman from a rural county, and not this state, but it could be this state, basically said, "I have evidence. I have jobs in my town." He had a state psychiatric hospital in his town. "That's my evidence. And you can show me all this data that you just showed me about how people will do better living in the community. But that's not the evidence that I'm looking at, and this really doesn't matter." So I would say scalability, finding ways to create more opportunities for these policy discussions to occur. Okay. I actually think that the most recent conversations about the fact that people have a right to live with disabilities, have a right to live in the most integrated setting possible, which, by the way, was in a law that was passed in 1990, and we're just talking about it now, okay? Those kinds of conversations can actually potentially lead to more effort at the federal level. Okay. Congress isn't at the table. There are 250,000 people on the waiting list for Section 8 in Chicago alone. And so it does come down to availability.
David, do you want to add a couple of points to that, and then we'll turn to our local?
Well, I think you covered it. There is this silo issue. One recent development is a health in all policies approach, which all the agencies have supposedly signed on to. Some people who don't like it call it health imperialism, but the point is that, there are different languages in both worlds. And so the federal government is operating these relatively tiny healthy housing programs, and we need to scale that up to look at it more broadly. And some of this is also data-driven. So if you're in Great Britain, you go to the hospital because you fell down a flight of stairs and you broke your arm, they will code in the hospital whether that staircase had no railings, one railing, or two railings. I mean, can you imagine? We don't do that here, and it's more complicated. Now, they have, single payer over there, so it's different. But that has led to, that sort of data-rich environment has led to a change in the way in which Great Britain inspects its housing. It's called the Healthy Housing Rating System. And they don't do such a great job on chronic diseases, but it is more health-focused. And so getting the data, as I said, doing the surveillance seems to me to be a key in building the evidence base, which I think is substantial.